Welcome everyone to our Ask the Doctor session tonight. My name is Shelley Korean with SkyPass Foundation. I'm so glad you guys have joined us for this discussion on a very hot topic, psychosis and behavioral disturbances in PD. I know many of you have had personal experience with this and have questions that you want answered. So here to answer all your questions about this topic is our guest for tonight, Dr. Daniel Weintraub from the University of Pennsylvania. Dr. Weintraub will be interviewed by Dr. Shilpa Chitnis, who sits on our board here at SkyPass Foundation. And of course, as always, if you haven't submitted a question with registration, you can ask us your questions live using the QA box at the bottom of your screen, and we will try to address those as best we can with the time that we have together. You can also interact with me and with each other using the chat box at the bottom of your screen. We do ask, though, that if you have questions specifically for the panelists to address, please put those in the QA box so that we can track those easily. The chat box tends to get a little active sometimes, and it can be hard to keep track of questions. So if you have any commentary or experiences that you want to share, any feedback, feel free to use the chat box for that. But for any panelist specific questions, please go ahead and put those in the QA box. So before we jump in, let's learn a little bit about our guest, Dr. Daniel Weintraub. Dr. Weintraub is professor of psychiatry and neurology at the University of Pennsylvania and psychiatrist at the Parkinson's Disease Research, Education, and Clinical Center. A board-certified geriatric psychiatrist, he conducts clinical research in the psychiatric and cognitive complications of Parkinson's disease. He serves on multiple task forces and working groups of the International Parkinson and Movement Disorder Society. He co-chairs the Cognitive-Behavioral Workgroup of the Fox Foundation-funded Parkinson's Progression Markers Initiative, it's a mouthful there, and is also associate editor of the Movement Disorders Journal, clearly someone who has a ton of knowledge and experience and expertise on today's topic. So Shilpa, over to you to get started with the interview, and I will see you guys here in the chat box.
Thank you, Shelley, and welcome, Dan. Really nice of you to be here. What we'll try to do today is, for the audience, we'll try with very basic stuff, and then we'll delve into more complex information, and we'll try to make it very simple. So I want to start with just really listing what is defined as neurobehavioral manifestations of Parkinson's disease.
Hi, Shilpa. So thank you to you and Shelley for the invitation and to be a part of this discussion tonight. So, as a psychiatrist, because that's my training, I'm a geriatric psychiatrist by training. When we talk about neurobehavioral complications of Parkinson's disease, we're talking in general about several or multiple major disorders, but there's many. But I would say the major ones that we focus on are what are called affective disorders. So that would include depression and anxiety, psychosis, which can include hallucinations and delusions, impulse control disorders and related disorders, what are also known as compulsive behaviors. And then fourth, and this is a little more, maybe, I don't know if it's controversial is the word, but cognitive disorders, in the sense that that's kind of shared between psychiatry and neurology, I'd say, but it's typically considered a neurobehavioral complication too. So cognitive impairment, whether it's mild cognitive changes or more significant cognitive changes that may meet the criteria for what we call dementia. And then beyond that, psychiatrists also consider sleep disorders to be a part of psychiatry. So there's disorders of sleep and wakefulness that are common in Parkinson's disease, disorders of motivation, such as apathy or amotivation. So there are some other disorders that kind of broadly fall under neurobehavioral complications as well.
Yeah, thank you. That's thanks for adding those extra, especially apathy and sleep disorders, very common, certainly. So can you explain to us now, again, each of these have, individual pathophysiology, but in general, can you give us a broad idea about the causation of all of these manifestations?
I think you can roughly think of it as two major contributing factors, although it's more complicated than that, of course. And the two major contributing factors would be the disease process itself, or the disease neuropathophysiology, that we recognize that for many of these disorders, the misfolded proteins that occur as part of Parkinson's disease, the alpha-synuclein that folds into Lewy bodies and deposits itself in different parts of the central nervous system. Depending on the location of that deposited protein and its spread throughout the central nervous system may help explain certain neurobehavioral complications or a component of them. And then the other contributing factor for some, but not all neurobehavioral complications would be the Parkinson's treatments themselves, whether they're Parkinson's medications or at times deep brain stimulation as another non-pharmacological treatment. So those would be the two major, but then of course there's other potential contributing factors such as genetics that can play a role for at least maybe cognitive disorders, but maybe even other ones as well, in ways that we don't understand yet.
Yes, absolutely. And then at what stage of the disease process do these symptoms manifest and why?
So I would say that the manifestations can occur anywhere from pre-Parkinson's disease. So now a very hot or ripe area of research focus is what we call prodromal or at-risk Parkinson's disease. So studying those people who for any one or number of reasons may be at increased risk of developing Parkinson's disease eventually, but don't have it yet. We know that there are certain disorders that are more common in that population, even before the onset of the motor symptoms. And those symptoms include depression, anxiety, and the strongest predictor probably is what's called RBD, that many Parkinson's patients will be familiar with, or rapid eye movement sleep behavior disorder. So what's called a parasomnia, where people physically and verbally act out their dreams. All of those can predate the onset of the motor symptoms of Parkinson's disease by many, many years. So that's an example of prodromal neurobehavioral complications. And then all the way through de novo untreated Parkinson's disease, symptoms can present themselves. And then many of them become more common, unfortunately, as the disease progresses and as people age.
Yes, absolutely. That is really interesting. I remember when I was in med school, this was in the late 1980s. This information was so foreign, you couldn't have imagined, right? That the
Right.
disease starts like so early before the motor symptoms manifest. So I think it's important for the audience to recognize that. So thanks for clarifying. And you kind of answered this, but maybe you can just briefly dwell on it. Is the neurotransmitters that are involved in these conditions?
Mm-hmm. So tying it back again to the disease process, in psychiatry and neurology, we focus on major neurotransmitters, what are typically called the monoamines, because they share chemical structure, similarities in chemical structure. So at the very base of the brain is an important collection of neurons that produce a neurotransmitter called norepinephrine that's associated with sleep and gait and balance and mood and even thinking, cognition. And that's perhaps one of the earliest areas of the brain affected by Parkinson's disease. And then as you move up the brain, you hit the areas that are responsible for producing serotonin, a key chemical or neurotransmitter that people may be familiar with. It's most closely linked in psychiatry with depression and anxiety. And then finally, you hit the area of the midbrain where dopamine is produced. And that's when we think that you start to see motor symptoms present themselves. But dopamine is also important for behavioral aspects of Parkinson's disease and cognitive as well. So, and then there's a fourth neurotransmitter called acetylcholine that's really most closely linked with cognition, also gait, but cognition. It's kind of the key neurotransmitter for which the original treatments for Alzheimer's disease were developed. But we know also in Parkinson's disease, there are acetylcholine deficits that occur even early in the course of the illness that may help explain some of the cognitive complications.
Yes, absolutely. Thank you. So moving on further, can you briefly comment on, you mentioned mild cognitive impairment. So what are the differences between mild cognitive impairment and well, not differences per se, but what is mild cognitive impairment and what is Parkinson's disease dementia?
Right.
I need more coffee.
Mhm. When you talk about cognitive impairment, and this is not specific to Parkinson's disease, because it's true for Alzheimer's disease as well. But when you want to classify people in kind of a simple way, which is how we often do it, because it's understandable and people know what you're talking about, even whether you're a lay person or a professional, we have three rough categories. One would be normal cognition, one would be mild cognitive impairment, and the third one would be dementia. So normal cognition means that the person essentially has the same or very close to same cognitive abilities that they had throughout their adult life. So cognitive abilities such as memory, attention, ability to problem solve, language, what we call visual spatial skills. So that would be normal cognition, and they haven't experienced any decline in any functional ability, not in a meaningful way anyway. Mild cognitive impairment means that there's identifiable cognitive deficits if you give somebody cognitive testing that you think that they're not performing as well as might be expected given their age and educational status, or compared with some kind of normal or normative sample that you're using, but that the person isn't so impaired that it's impacting on their daily function. So they're still able to perform what we call your high-level activities of daily living, driving, shopping, financial planning, the kinds of things you need to be able to do to survive day to day from a cognitive standpoint. And then the third category would be dementia, where the deficits tend to be more severe on the cognitive testing, and the deficits are such that they are impairing one's independence. You're no longer functionally independent, but really requiring assistance. So when somebody reaches that stage, that's what we call dementia.
Absolutely. But even in patients who have, just early Parkinson's disease, you do see it's not equivalent to MCI, but you do see some things, like some issues. Like if you did a cognitive testing on them, like you'd say, like, they can't do set shifting, or they have, some problems with getting their words out. And what can you comment on that?
That is common. So you are correct. Often those people, if you give them a detailed battery of tests, will perform in the normal range overall. They might not be as high as they used to be, but it wouldn't fall into the normal level of what we would call impairment. I would say the most common ones you've already listed early on are word finding problems. So tip of the tongue phenomena. Somebody knows what they want to say, but they just can't get the word out. Often early on, they will find the word eventually, they just can't do it in the moment.
Yeah.
I would say attention changes are common. So people report feeling unable to sustain concentration or attention the way they used to, where they get distracted more easily. That is another common complaint. There's even can be some mild memory problems. So people may find that particularly their short-term memory, as opposed to their long-term memories, is something that's happened relatively recently. They may have more trouble recalling than previously. People may have more trouble with multitasking. So juggling two activities at the same time, or shifting easily from one activity to another. So those are some of the more common complaints.
Yeah, absolutely. So, we know more about genetic forms of Parkinsonism now, since in the molecular era, we've been able to identify quite a few genes. So are certain genetic forms of Parkinsonism more susceptible to developing cognitive impairment?
I'd say we know the most about the more common ones. I mean, when something's rare, it's hard to know for sure. I'd say the one that's associated with worse non-motor symptoms or neurobehavioral symptoms, particularly cognition, would be Parkinson's patients who are GBA positive or glucose cerebrosidase positive. And that's one of the more common. I mean, none of these are very common. Most people have what we call, as you know, sporadic Parkinson's disease, but of the genetic forms, GBA, and people that have even more rare, triplicate, triplication of the synuclein gene also tend to have more significant cognitive impairment. On the other hand, people that are LRRK2 positive, one of the other common genetic variants, tend to have a pretty mild course, at least early on, in terms of neurobehavioral complications. And then there's the whole, not genetic forms of Parkinsonism, but specific genes, whether you have Parkinson's or not, that are implicated in things such as cognitive impairment. The most common one would be what's called the ApoE4, apolipoprotein E4 gene, which is one of the major correlates for Alzheimer's disease. Well, if a Parkinson's patient has one or more ApoE4 genes, they're also more likely to have cognitive issues compared with someone who doesn't have one of the ApoE4 genes. But that has nothing to do with having Parkinson's disease.
Yes, absolutely. I mean, I have patients who have Parkinson's disease and then have Alzheimer's disease, on top of that as a separate entity. So thank you. It's interesting. I just have to add this. I was just reading a paper a couple of nights ago where they found that if you have a GBA mutation, then you are at a higher susceptibility to developing cognitive complications with bilateral ST and DBS.
Oh,
so
right. I think,
we were in the. Do you agree with that, or?
It sounds familiar, and I do think I remember reading that as well. That it makes you more susceptible to a treatment complication in this case.
So we were in the neuromodulation clinic, and I was mentioning to my surgeon, at what point, should we start just screening people for? Obviously, we are not in Europe, and we don't do genetic testing very easily, and insurance doesn't pay for it. But these are things, I guess, to keep in mind, because you could use a different target. I mean, you could use GPI, right? I mean, instead of using STN.
Right. And I think you're right. We're not there yet where we do that routinely for testing for DBS evaluation. What is good is that it's much more common that at least people get detailed cognitive testing before deep brain stimulation surgery as part of the evaluation process. In the past, that wasn't necessarily common or universal. I think now it's near universal, at least in good academic centers, that they just don't want to take a risk of operating on somebody that is known to have significant cognitive impairment before the surgery.
Yeah, absolutely. I remember when I was a fellow, I don't remember we did a lot of cognitive testing. I mean, we didn't even know who to send them to. But now for Parkinson's patients, we routinely do cognitive testing. We do a pre-screening MOCA, but we do cognitive testing for pretty much everybody. So yeah, thank you. So what is your approach to management of MCI and Parkinson's disease dementia? I mean, do medications really work? Is there even a point in starting these people on medication? Because, my biggest worry is you have these poor patients on a high dopaminergic load already. Then they are, orthostatic from the disease and medication. And on top of that, if I'm going to put them on, Aricept or Exelon, then that, is aggravating those side effects even more. And my last, just in addition to that is that, just based on some comparative results, that Razodine or galantamine might probably be better than Aricept or Namenda. So I think I asked you a lot of questions in one line, but they're all connected to each other, I guess.
We certainly started with the most difficult topic. I mean, I think if we're going to be honest, we would say that cognitive impairment is really the most worrisome longer term complication for Parkinson's patients, and rightly so. And it's also really the most difficult to treat, in that we have the least evidence for efficacious treatments at this point. And on the promising side, it's also a very active area of research. There are many clinical trials that are ongoing for mild cognitive impairment, for dementia. So that's good. For dementia, there's only one FDA-approved medication for the treatment of Parkinson's dementia, and that is a medication that was imported from the Alzheimer's field. It boosts the level of that one chemical I mentioned earlier, acetylcholine. So it's called acetylcholinesterase inhibitor, and that's ribostigmine, or Exelon is the other name for that. And it was shown to have benefit, but it is modest benefit for Parkinson's. It's also modest benefit for Alzheimer's disease. There's two other compounds, as you mentioned. One of them is galantamine. The other one is donepezil. So there's 3 to choose from. So we do use them. I think they're still underutilized in Parkinson's disease. I think many people with significant cognitive impairment are not taking one of them, and there's really no reason not to offer somebody a trial of that. I think overall they're safe and well tolerated. The other medication that's approved for Alzheimer's and is used in Parkinson's, but for which there's less evidence, is one called memantine or Namenda, and that affects a different neurochemical pathway, neurotransmitter pathway, glutamate primarily. And that has not shown significant benefit in a few Parkinson's disease studies, but we do use that clinically to often augment or complement the cholinesterase inhibitor. That's really it on the approved medication front. And again, that's true not only for Parkinson's disease dementia, but for Alzheimer's disease as well, other than the addition recently of the aducanumab, the amyloid immunotherapy that was just approved. I think and then for mild cognitive impairment, there's really never been a large scale positive study. And part of the reason we think is maybe it's the choice of the compound, but also because people are not so impaired with mild cognitive impairment from a cognitive standpoint that it's hard to show a benefit in cognition for what we call kind of a ceiling effect. They're too close to their normal state to show much improvement. So we don't really have an approved medication for milder cognitive changes. So then what else can you do? You take steps that will kind of help preserve cognitive health, we think, or may have some cognitive benefit. And that includes things like treating comorbid vascular diseases, it's called. So things such as high blood pressure, high cholesterol levels, diabetes, all of which, if unchecked, can damage blood vessels in the brain that are responsible for cognitive abilities. There's certain specific symptoms that are relatively common in Parkinson's disease that are also associated with worse cognition. Obstructive sleep apnea is relatively common in Parkinson's. We know that if people don't use a CPAP machine, they tend to do worse cognitively than if they're on a CPAP machine. People with orthostatic hypotension, so when your blood pressure drops significantly when you're in a standing position, people tend to do worse cognitively. We think there might be some benefit from exercise programs, physical exercise, cognitive exercise, that may have either acute or even maybe longer term benefit in terms of cognition. Psychiatric symptoms have been associated with worsening cognition long term, both in Parkinson's and non-Parkinson's patients. So we think if somebody has an existing psychiatric disorder, that it's important to treat it. And a very important area of research is the contribution of what are called anticholinergic medications. And the example I always give for that is the sleep medication commonly used in the elderly, Tylenol PM, or people use Benadryl. These are medications that have medications with anticholinergic effects that can impair cognition. So we tend to look at the existing medications that somebody's taking, not only their Parkinson's medications, but non-Parkinson's medications as well. So those are all some of the things we can do without an identified medication to give to people while we're working on research efforts to develop new treatments.
Yes, this is really wonderful information. It's interesting you mentioned that, I always try to tell my patients is, if any of your other doctors puts you on a medicine for anything else, just drop me a MyChart message and let me know so that I can take a look and see if this is going to adversely affect, you in any way, whether your motor function or your cognitive function, right? So I think this was medications a very important point, because sometimes you're all too quick to just pop a pill and, not worry about it. So very important point. Thank you. So switching gears, let's talk about, something which is, I think, really not addressed very well in patients with Parkinson's disease, because there's still such a, I wouldn't necessarily stigma, but there's some embarrassment with like anxiety and depression. A lot of the times that people suffer and, just live with this because they're all too embarrassed to ask the doctor, say, oh my God, how can I see a psychiatrist? That's just not something, people want to do.
Right. Yes, I'm in that position, that familiar position of people often not wanting to see me, and that's understandable. And I'd say most mental health care is not provided by psychiatrists to Parkinson's patients. It could be, and my bias would be that it might be good to have that, but neurologists end up having to deal with a lot themselves. Primary care providers deal with a lot of psychiatric, just because there's many more of them available than geriatric psychiatrists such as myself, or people that are interested in Parkinson's specifically. So it's just hard to access people with psychiatrists with expertise in Parkinson's disease. I've been surprised that I think this is probably the biased sample maybe that I see, is that I think people are actually fairly open to discussing mood disturbances, anxiety symptoms. And it's interesting, even though we know there's a strong biology contribution maybe from the brain changes I talked about before, everything that happens from a biological standpoint that gets filtered through your psychology somehow. So people have psychosocial stressors. They have the diagnosis of Parkinson's disease to deal with. Depending on the age of onset, they may be still working and raising a family, so that can clearly have added stress. So there's lots of reasons people worry about their future, what the Parkinson's disease is going to mean for them. There's all kinds of psychological issues at play. And that's why I think it's good to offer people, if treatment is warranted, the option for pharmacological treatments such as antidepressants, but also psychotherapeutic approaches such as psychotherapy, of which cognitive behavioral therapy is the most common, or some combination even of those two.
Yes, and those sometimes I think cognitive behavioral therapy is so underutilized, especially like for anxiety. Probably it works maybe even better than medications. I'm not a psychiatrist, but you're right that what I tend to do is I tend to send my note to one of my psychiatry colleagues, knowing how long their wait times are, and I say just take a look at these medicines, and maybe you can suggest what would be a good medicine that I can start them on. So while they're waiting to see the psychiatrist, they can at least, because in older people, I suspect that these medicines take like 8 to 10 weeks before they can start to show some benefit. Isn't that right?
Yeah, I'd say that if you're not seeing any benefit, this is how we're trained anyway. If you're not seeing any benefit within 3 to 4 weeks, like no improvement, then you should be doing something. Sometimes that's something maybe just be increasing the dose. Typically a full trial of an antidepressant would be 6 to 12 weeks. So certainly by 10 to 12 weeks, whatever improvement you're going to see at that dose, you should have seen by then. And the same problem kind of exists for psychotherapy access as it does for psychiatry access. Having a truly skilled cognitive behavioral therapist is not so common, particularly one that has experience working with Parkinson's disease, which is very a nice feature to have because of all the specific aspects of Parkinson's disease that are kind of unique to the illness. So if you have a cognitive behavioral therapist, ideally it's somebody who's experienced with Parkinson's patients. The one nice thing that's happened there, I'd say both for psychiatry and psychotherapy, is that the pandemic, one of the silver linings, one of the few silver linings maybe, is that it's made us realize that we can deliver psychiatric care, psychotherapy care virtually. So it makes us much more available to people, particularly for psychotherapy, because in the past, people would have to come in for weekly appointments for 10, 12 weeks, and that might not be so easy for a Parkinson's patient. If you can do it via video from your home, it makes it much more accessible to people.
Yes, definitely. And again, because I spend so much of my time doing deep brain stimulation surgery and programming, that really like uncontrolled anxiety and depression are, contraindications to being considered for DBS.
Well, that's interesting because so this is maybe where we have a difference of opinion, because I personally don't think that they should be contraindications, but that's based on my clinical experience.
Oh, I'd like to hear your input.
Well, my experience, and I think research bears it out, is that most people, so on average, people's psychiatric symptoms improve with deep brain stimulation. So if you just take a depression score, a rating scale, and give it to 100 people who go through deep brain stimulation, their scores on average get better. And similar for anxiety, and similar for some of the other disorders like psychosis and impulse control disorders. And the reason for that is probably multiple. It may have to do with medication adjustments afterwards. It may be improvement in motor symptoms. So I do think that there are people that you wouldn't want to have get deep brain stimulation because of psychiatric issues, like if somebody was acutely suicidal, let's say. But I think those patients are in the great minority. And I think as long as somebody's overall stable from a psychiatric standpoint, I don't think mood or anxiety symptoms, if anything, I think they probably will do better afterwards. That's my experience anyway.
Yeah, I mean, what I meant was like, if they're really uncontrolled, like, they're, I mean, like you said, it's multifactorial, it's the disease, it's a reaction to the disease, but also the neurobiology of Parkinson's leading to anxiety and depression. So that's why we really have the psychiatrist talk to them and weed them out. And we ask them to, if they feel comfortable that the patients can be implanted, then, we've definitely implanted. But we've had experiences where somebody had a panic attack, uncontrolled anxiety, panic attack on the table. So, I think it takes just one bad experience to, but
Right.
I think your point is very well taken, that improvement in motor symptoms and reduction in the medication load can certainly result in improvement in these things.
Yeah.
So there's a
Well,
balance, I think, to be struck.
And I do see your point as well, which is you have to get through, you have to be with it enough or stable enough to get through the surgery, through being set up for programming. And it's a very stressful experience, obviously, the surgery, the post-operative care. So you need somebody who's in a strong place mentally to be able to do well with that.
Yeah, and again, we can use a different target. Like, I mean, GPI is definitely more sparing. So in people that have, anxiety and depression, we don't necessarily cancel them out because they have that, but then we, use the GPI target, and I think that has worked out pretty good. Okay, so switching gears to psychosis, I think this is a very scary. I will tell you, I went when Nuplazid first came or was going to be introduced at one of the meetings. They had this virtual reality booth,
Yes.
and
Yeah.
I went in there, and with all the gear and stuff, and then you're just there. It's like dark, and you have no warning, right? So suddenly, like a head bobs out of the door, or sometimes there's like this, snake that popped out. I mean, it was scary, although I knew that this was a simulation, but that in itself was like, very scary. So can't imagine how scary psychosis is for somebody that is, experiencing it. Now, of course, I mean, there is psychosis without dementia and there's psychosis with dementia. And I guess there are two different things. So perhaps you can comment a little bit about psychosis, what causes it, and how you would address it.
So this is a case, I think, where there's a mix of both the disease pathology, as we call it, and the medication effect, the Parkinson's medication effect. So there's multiple imaging studies that show impairments in the visual pathways that may help explain, for instance, why somebody may have a visual hallucination, and changes in the serotonin system specifically, which gives biological support to why we use a compound like pimavanserin, which is a very pure serotonergic compound, or even other atypical antipsychotics, as they're called, which also focus more on the serotonin system. So that's kind of the disease process angle of it. And we also know from other studies that psychosis is not common, or it's rare in patients who are untreated with new onset disease. And it just becomes more common as the disease progresses, but also as they get on various Parkinson's medications, and certain medications are more likely to cause it than others. So for instance, dopamine agonists might be one that's more associated with it than levodopa, but even levodopa in higher dosages can be associated with these hallucinations or delusions, as they're called. So it seems to be a mix of the disease process and the medications. Some people have very mild symptoms and tolerate them okay and don't need treatment. So people who may have what we call passage or presence phenomena, so detecting something in the periphery of your vision, a sensation that something's there, a person's there, something's moving, or misidentifying an actual object that's in front of you. So there's something there, but you think it's something else. And then after that, you can develop more formed hallucinations, which still some people live with, and they realize they have some insight. Maybe that's where you're talking about people that are not so cognitively impaired that they can't recognize that this is kind of their mind playing tricks on them. But then as people become more cognitively impaired and have these symptoms, and then maybe start to develop altered thinking,
Sorry.
and this is and they have cognitive changes, then they may typically lose their insight. And that's when things can become more of a problem, particularly people can have agitation, it can interfere with sleep. There can be a lot of stress in the house, caregiver burden. So in the more advanced stages.
Yes, absolutely. And, I've recognized this patients with advanced disease who are, in wheelchairs, they probably don't need as aggressive dopaminergic management as, we would do it earlier in the course of the disease. So I've actually become a firm believer of trying to just simplify them, bring them down to levodopa, and even not having such high doses of levodopa. And, so maybe they're slightly slower and they shake a little bit more, but then they're not hallucinating anymore. What do you think about, just the use of cholinesterase inhibitors? We talked about, Aricept and Exelon. Do you ever use them as first line agents before you go on to something like pimavanserin or Seroquel?
I do, not because there's so much evidence that they treat hallucinations or prevent hallucinations or psychosis more broadly, but because patients often already have some cognitive impairment as well, and I figured they probably should be on the cholinesterase inhibitor anyway. But there was some preliminary evidence that cholinesterase inhibitors may have some protective effect or treatment effect for psychosis, but I think that evidence is not strong at this point.
Yeah.
So I often do it, but not necessarily just for that reason.
So if you've done everything, you've taken them off all the medications, now you're on really simple dose of levodopa, or you're on Exelon and they're still, hallucinating, and we've ruled out infections and metabolic stuff. So what is your go-to medication? Is it quetiapine, or is it pimavanserin, or is it something else?
Well, I think it's hard to say. I mean, I'd say the first line agent is one of two antipsychotics. If you're going to use an antipsychotic, there's one that's traditionally used and that neurologists feel comfortable with, but one for which we have relatively little scientific evidence, and that's quetiapine or Seroquel. And then we have one that was approved, you mentioned it already, the pimavanserin or Nuplazid, that was approved 6 years ago by the FDA. And that's specifically for Parkinson's psychosis. And that does have scientific evidence from a couple of studies now of benefit for Parkinson's psychosis. So I think if you're going to go on the basis of scientific evidence, then pimavanserin has the strongest evidence. It's a little more complicated to use because you have to go through kind of a registry and approval process. And so it's comparing apples and oranges in some way. And then the third medication, which is clearly, I think, for most people, a second or third line agent, is clozapine, another older atypical antipsychotic for which there's also evidence in Parkinson's disease, but it's much more rarely used because you have to have blood drawing done on a regular basis to keep an eye on your white blood cell count.
Yeah, no, absolutely. And I always worry about, people being in the hospital and being put on olanzapine or risperidone, which, are not medications that we as moment design neurologists like. What do you have to say about those?
Yeah, I would say those are fourth and fifth line agents. Now, sometimes by the time I see somebody, they've already failed everything else. So I have to think creatively. And sometimes it does mean using something that we'd rather not use. But if you do things in a very, as you know from your own clinical experience, if you do things in a very cautious manner, you can sometimes try things. If you start at a very low dose and you have very close observation of worsening in motor symptoms, for instance, you can often at least give a trial of something to somebody, particularly if they've failed 3 or 4 medications already. Sometimes you have to do that because these problems are so disabling. Sometimes you have to keep trying things.
Yeah, no, absolutely. I agree with you. My worry, of course, is that, when a patient is sent to me that I've not followed for years and years, and if you don't know whether they really have Parkinson's dementia or they have dementia with Lewy bodies, and I worry about giving antipsychotics to somebody that might be having dementia with Lewy bodies. Just
right. I agree. My usual statement to people is whether you're talking about neurological treatment or psychiatric treatment in Parkinson's disease, it's trial and error. You can try something as long as you explain the potential adverse events up front, do things in a cautious manner. almost everything we give, to my understanding, at least psychiatrically, and I think that's probably true neurologically, is reversible. So if you need to stop a medication, you can do it, and there's no lasting harm from these things typically. So I try to reassure patients, if you have a symptom that's worth treating, then we can try it, and we'll just keep an eye on things, and we'll adjust accordingly.
Yeah, no, absolutely. And I know people have lots of questions, but I just want to ask you your last comment about is impulse control disorders and dopamine dysregulation syndrome. I think these are really important topics.
Yeah, so that was kind of the start of my research career close to 20 years ago. And that was at the time when dopamine agonists were the first line agents. So there we're talking about medications at that time was pramipexole and ropinirole primarily, or Mirapex and Requip, and subsequent to that rotigotine or Nupro patch. And an association was found fairly early on of dopamine agonists causing typically one of four major disorders that can present in other ways, but compulsive gambling, sexual behaviors, buying and eating behaviors. And we recognized pretty quickly through studies that there seemed to be this strong association with dopamine agonist use, that maybe 15 to 20% of patients treated with one of these dopamine agonists develops this one or more of these problems. And as a result, the prescribing for early Parkinson's patients has changed. So now they typically are not started on the dopamine agonist first, and maybe an MAOB inhibitor or even levodopa now. And dopamine agonists are more complementary medication. And I think people are much more mindful, neurologists, of monitoring for these symptoms. And you really need to monitor forever if you're on one of these medications. You can't assume that because you didn't have a problem in the first 6 months or a year that you'll never have a problem, because that's not true. And the other disorder you mentioned, dopamine dysregulation syndrome, is similar but different. It tends to occur with levodopa, so the more short-acting dopaminergic therapy. And that's when people are escalating on their own, typically, levodopa, and taking higher dosages and shorter duration between doses, so every hour, every couple of hours, and they get on so much dopaminergic therapy that they can develop a rapid cycling kind of mood disturbance that can be very problematic for patients.
Yes, absolutely. I remember when they were studying dopamine agonists for even restless leg syndrome, that even at lower doses with long-term use, that perhaps some of the patients develop some impulse control disorders. So now every dopaminergic medication has in the prescription information, the warning about impulse control disorders, including amantadine and including, Azilect. So it's interesting.
Yes, and every new Parkinson's medication has to test for impulse control disorders as part of the FDA approval process.
Yeah, thank you. Okay, so thank you so much. These were my questions, and now I'm gonna quickly go. There's a lot of questions here, and I'll try to see how many I can go through.
Okay.
Dr. Weintraub, you recommend that a person with Parkinson's have both a neurologist and a psychiatrist. I think you kind of addressed that, but
I'm sorry, should have both a neurologist?
Yes, should have both a neurologist as well as a psychiatrist.
What maybe access? I mean, if I was going to have a dream Parkinson's management team, I would include a movement disorders neurologist, not a general neurologist, but movement disorders neurologist trained, a psychiatrist with experience in Parkinson's disease, access to a neuropsychologist for cognitive testing, a psychologist for any psychotherapy like cognitive behavioral therapy, a speech pathologist that can do speech and swallowing assessments even, an occupational therapist and a physical therapist, a social worker to address the myriad number of psychosocial needs that tend to arise during the course of the illness. And then even, know I'm leaving something out, but a pharmacist. So we, for instance, a couple of our Parkinson's centers, including the Department of Veterans Affairs, we have access to a pharmacist, which is very helpful. So I think that would probably cover it. And sometimes you need very specialized services, like a particular type of occupational therapy to do driving evaluations, which often arises as an issue in the context of Parkinson's disease.
Yeah, and we also have a gastroenterologist and a urologist.
There you go.
So it's what you're basically saying is the multidisciplinary, approach to taking care of patients. Yeah. Absolutely. Ken wants to know, after a sudden onset of a month of PD hallucinations 2 years ago, my husband began Nuplazid, which has been a miracle. No hallucinations until another sudden brief one a month ago. He's been diagnosed with Parkinson's for about 7 years. Does that mean that Nuplazid is no longer working?
I've always been hesitant to assume that when any psychiatric medications, the symptoms re-arise, that it means it's not working, because you never know what things would have been like if you weren't on the medication. But when we have an acute occurrence of psychosis, whether it's for the first time or a recurrence, the first thing you want to do is do a basic medical evaluation to make sure there's nothing medical going on, like a urinary tract infection, which can also cause similar symptoms. I'd be curious to know if there have been any changes to the Parkinson's medications or other medications that might help explain this. And if it's a short-lived episode and it's already resolved, then that's good. The other thing that happens over time that we can never account for is that people get older over time, and the disease probably has some progression. So maybe it's not just that the medication stopped working, but that something in the brain has changed over a year or a couple of years. So there can be multiple contributing factors that may lead to this kind of a recurrence.
Yes, absolutely. John wants to know, with such broad symptoms, especially non-motor symptoms like apathy and other psychological issues, would a cure for Parkinson's be what most people think it is, or would it be more targeted to certain symptoms and others would still need to be treated?
I guess it depends what the cure is. So the ones that people are focusing on right now, what they call disease modifying therapies is one term that's used. So for instance, immunotherapies that are attacking the synuclein that forms the Lewy bodies in one way or another. So if you're trying to decrease the amount of pathological, as it's called, synuclein or Lewy bodies in the brain, that should have a broad effect across motor and non-motor symptoms, because the less disease pathology you have, the less non-motor symptoms you should have as well, because we think it's the spread of this to various regions of the brain that's responsible for these non-motor symptoms. To the extent that those disease modifying therapies then also lead to less need for Parkinson's medications, then that should lead to a decrease in symptoms such as psychosis and impulse control disorders as well.
Absolutely. Thank you. Is there any proven food or drink that can improve dementia symptoms? Husband likes some junk food every day, and at the stage of his PD, I just give it to him, but I wonder if it's a mistake.
At some point, you have to be able to enjoy life as to the extent possible. And so people often ask me about a drink that they might think, should I have a beer or a glass of wine at night, or should I not? And I typically say you should, because you should try to have some enjoyment in life as well, especially when there's no really clear evidence that doing differently makes much of a difference in the long run. So I think it's the obvious recommendation is to eat healthy and exercise, but it's also true that we don't really know that it makes a big difference in terms of long-term outcomes. So I wish I could give more science to that statement than I can. So I don't think there's evidence really that diet or exercise or cognitive training definitively makes a difference in the long-term outcomes of Parkinson's patients.
Absolutely. And as healthy as I have been eating for the last 2 years, I just ate a whole box of this afternoon while I was working. So I think it's important to enjoy your life. Is pseudobulbar, crying or laughing at inappropriate times, caused by PD? Is it unusual or common? Is it usually treated with medications?
So the person who asked that question is asking about something called pseudobulbar affect, which is a relatively common symptom in Parkinson's. I wouldn't say that it's that commonly serious or significant. It occurs across several what we call neurodegenerative diseases, Parkinson's being one of them, but the more common ones are actually multiple sclerosis and ALS, or amyotrophic lateral sclerosis. And it's in a sudden expression of laughter or crying. My experience with Parkinson's patients, it's more often crying than laughter, where it just seems to come out of the blue, or in a kind of with minimal what we call provocation. So maybe watching a sentimental movie or having a sentimental thought and then breaking into tears, and then it tends to be relatively short-lived and go away. but it's different than how the person used to be. We think this is very much a disease effect, and the center of the brain that's kind of responsible for that is in the bottom part of the brain, that kind of earlier part of the brain that I mentioned can be affected in Parkinson's. So, and there are treatments for that. And there's FDA approved treatments, but we also use antidepressants commonly. It doesn't mean the person's depressed, but antidepressants seem to help with curbing these sudden outbursts of crying.
Yes, absolutely. Thank you. I'm interested to hear if either of the doctor has an opinion on the use of infrared light treatment for PD and Alzheimer's.
I do not. I'm not aware of any research really suggesting that that's a treatment. There's lots of treatments being studied for both Parkinson's, dementia, as I mentioned, or cognition and Alzheimer's, but I'm not aware of that specifically.
And I mean, I'm just looking up in my sources, in the monkey model, infrared light has proven to be neuroprotective. I don't think I've come across any human studies that I can.
But since the person asked that, I think the other area that's very active in research in psychiatry, but also I'd say cognitive research more broadly, are stimulation therapies. So transcranial direct current stimulation, repetitive transcranial magnetic stimulation. There's a whole range of those. There's one called intermittent theta burst stimulation. These are all things that use either magnets or electrical stimulation to the outside of the brain to either treat mood disorders or maybe to have effects on cognition even. Sometimes some of the stimulation therapies are paired with computerized cognitive training. So you're trying to train somebody at the same time you're stimulating their brain. So these are all some of the novel treatment approaches. I think it's more at the research stage at this point and not really ready for clinical use, but that's kind of where the field is, one area where the field is really focusing on.
And I recall that, many, many years ago that there were studies with TMS, even for motor, symptoms of Parkinson's, but I don't think that this has really gone anywhere, in large studies per se. But I think for depression, perhaps there is more of a role, isn't it?
Yeah, clearly in the general population, there hasn't been so much study in Parkinson's, and I think our TMS, repetitive transcranial magnetic stimulation, is quickly coming up against other competitive treatments like what's called intermittent theta burst stimulation, which is a modification of this transcranial magnetic stimulation. So there's a lot of exciting areas of research for mood and cognitive disorders, I'd say.
Absolutely. Can you discuss sundowning? Seems to be what my husband has, but it occurs different times of the day.
Mm-hmm. When I hear sundowning, I mean, the typical scenario for that is somebody who has significant cognitive impairment and has a worsening of behavior and cognition, so confusion, let's say. The most commonly reported time for that is the late afternoon and early evening hours, but it can happen other times of the day. And we don't really know why it happens. If there's some alteration in brain activity or brain waves that might be even detectable by an EEG machine that might help explain it. When I hear about fluctuations during the course of the day, though, beyond just sundowning, I also think of what we call non-motor fluctuations. So these are Parkinson's patients who, with established disease and frequent dosaging of levodopa particularly, can develop on and off periods, both from a motor standpoint, so they're in pretty good shape when they're on, but then as it wears off, they go into an off state. But they can also develop non-motor fluctuations where they can become cognitively impaired or more impaired. They can get quite anxious. So they have a lot of non-motor or psychiatric symptoms as the medication wears off. And then it tends to improve as they take their next dose of levodopa. And that can happen multiple times during the course of a day, time to the medication.
Yeah. Kathleen Shada says, I have MSA. I had hallucinations about 1 year ago after diagnosis. It was controlled by Abilify. How likely are the hallucinations to reoccur? How common are hallucinations with MSA, and what are the possible causes?
I think we know relatively little about neurobehavioral complications in MSA. We didn't used to think that cognition suffered at all in MSA, but now more careful studies have shown that there can be mild cognitive changes in MSA. I would just say more broadly, not specific to MSA, that if you're on an antipsychotic with a neurodegenerative disease, we try to treat, but also think about ending treatment at some point, or at least having a trial off of treatment. And the reason for that is whether you're talking about Alzheimer's or maybe even Parkinson's, there might be a slightly elevated, what we call mortality or morbidity risk with exposure to these medications, which means that if the likelihood of having death or even some medical event like a hospitalization or an ER visit for unexplained reasons maybe is slightly higher if you're on one of these medications. So we try to treat the symptom, but then once the person's been stable for some time, we at least consider and talk to the patient about the possibility of discontinuing the medication to see if the symptom is going to recur. As you were mentioning earlier, Shilpa, I think all of us as clinicians, we end up just adding and adding things, and it's less common that we think, what can we take away to maybe improve the situation?
Yes, absolutely. One of the things that I do at least once a year when I see the patients is actually really go through all of the medications and really see, what do they really need to be on. And I really make a list of things that they need to come off and, send a note to their primary care doctor. And I think it really helps. I mean, it's just a medication load. And then sometimes patients tend to take so many supplements that have no proven benefit, just a lot of medicines. If someone does not have an obvious deficit, would a neuropsychological test be recommended to establish a baseline?
I think multiple ways to answer that question without knowing more details. I think that every Parkinson's patient at the time of diagnosis should have at least a screening test done for cognition. Like the most commonly used one is, people are probably familiar with, is called the MoCA or Montreal Cognitive Assessment. Something that can be done in about 10 to 15 minutes, let's say, that gives you that baseline that the person was asking about. I think that should also apply to neuropsychiatric symptoms as well. They should have their mood assessed for anxiety. And I think really that kind of screening should be done annually throughout the course of Parkinson's, because I think otherwise it's too easy to miss things. Neurologists in particular are too busy asking about other symptoms, and you tend to overlook it. There's just not enough time to ask all those things. And there's a way that there's screening instruments that patients can complete themselves prior to a visit that doesn't have to take up the physician's time to do this. A physician can just review the results. So I think that's really, to me, the take-home message is screening regularly starting at disease onset.
Yes, absolutely. One of the things that, I've been doing, again, as you said, Dan, it's really with the time that we have 30 minutes, sometimes the patient is late, sometimes we're running late, we don't always get the time. So one of the things I've been doing is, just printing out the non-motor symptom questionnaire, which is a very detailed questionnaire. And I'm really working on with the EPIC people to see if I can send that to the patients even before the visit. And if they can print out and bring it to me, and then I can go through that and address the issues that are of relevance, as opposed to, asking them about, which I still try to, I have lots of smart phrases, but it's hard, right? It's hard to,
Right. So as you know, that instrument, the NMSQ, as it's called, was developed by Dr. Ray Choudhury and colleagues in London. And working with him and other colleagues, we've recently updated that instrument to something called the MDS-NMS. It's a 52-item non-motor rating scale discussing all of the symptoms we talked about tonight and other ones as well. And now we're in the process of developing a self-rated version built off of that. It will be the same number of items, but something a patient can just complete on his or her own at home, as opposed to having a rater administer it. So it'll be similar to that NMSQ that you're talking about, but a more updated and comprehensive version of that.
Yeah, absolutely. Let's see, I'm trying to filter through some questions. What is the issue with olanzapine? Somebody wanted to know.
Well, olanzapine is an atypical antipsychotic, which is good, but it has tends to have more side effects, particularly worsening Parkinsonism. So that's the main concern with other antipsychotics besides the ones we talked about tonight, or not only is there limited evidence that they work, but they may worsen tremor, slowness, stiffness, gait and balance, because we already know that these are side effects of these medications from studies done in schizophrenia or studies done in Alzheimer's disease. And if anything, Parkinson's patients are going to be even more vulnerable to those side effects.
Yes, absolutely. How to deal with fear of and preparing for possibilities that lie ahead for a patient?
Well, I mean, it depends how old you are, what stage of the illness you are, stage of life. But I get asked, I'm going to answer this in a very specific way, because the question I get asked the most is, I'm worried about what the future holds for me, or I saw this video about Parkinson's disease and I'm dreading that I'm going to end up like that, or I don't want to go to a support group because when I went, everybody was talking about all the horrible things that can happen to me. So my general response is, particularly for people that are newly diagnosed or early in the illness, is you really don't know what's going to happen, because Parkinson's has so much variability in it from person to person that you may have a more rapidly progressive course, but you very well could have a slowly progressive course over many years. I mean, we all see patients that have had it for 10, 15 years or longer and are still quite mild. They're cognitively intact. They have relatively, mild motor or non-motor symptoms. So the more you can worry and fret about it, and that's understandable, but whether that actually means that you know what's going to happen is something quite different, because none of us do, not even your providers who are experienced and trained can really predict very well what's going to happen to you.
This is very true. Dr. Rao, who I trained with, used to say, to patients, I left my crystal ball at home, and not to be facetious, but you're right, that there is really hard to, to predict the future.
That's a good response. I like that.
Maybe we'll take one last question. Somebody says that University of Texas is currently conducting a trial on stem cell treatment for PD. Are you familiar with the study? If so, or if not, what are your thoughts on stem cell treatment for dementia?
Yeah, I'm not aware of stem cell treatment for dementia, and I wouldn't be the person to answer about Parkinson's motor symptoms in general, because I'm not up to date on all those studies. There have been studies in Alzheimer's for growth factors that are not stem cells, but maybe have some kind of similarity to that. But I'm not aware of anything particular for Parkinson's cognitive impairment anyway, but there's studies that I'm not aware of, the small preliminary studies that could be ongoing.
Yeah, and it's certainly not UT Southwestern, because I work there, and I'm not. I mean, we always, so one of the things that we do once a month is we discuss all the studies that we're all doing, so that so that we can help each other recruit patients. So I don't know which UT. I mean, there is UT Houston, UT San Antonio. So I'm sorry, John, I'm really not aware. And I think we're we are at time. So Dan, thanks so much, and I'm going to turn it over to Shelley.
You're welcome.
Thanks, Shilpa. Dr. Weintraub, I have one last question for you. I know we're at time, but there's just one last question here. We have quite a few folks with early onset PD on here. And so for their benefit, I just want to see if this question can be quickly addressed. What percentage of early onset have been medically treated with levodopa? What percentage of those patients develop psychosis and or dementia? And are women more or less prone to developing psychosis or dementia? Is there a brief answer to that question?
I think younger onset patients tend to do better overall, particularly in terms of cognition, until they get older. So if you are diagnosed with Parkinson's disease at age 50, you're likely to probably have many years of good cognition. If you're diagnosed with Parkinson's disease at age 80, then it's more likely that you'll develop cognitive impairment sooner than later. If you're treated with levodopa at a young age, you're at a higher risk of developing dyskinesias, that extra movements that people are prone to develop with levodopa. There are also maybe younger age onset is associated with things such as impulse control disorders that I mentioned before. So that may be another risk factor, but I can't say the psychiatric course otherwise is that much different. In terms of male versus female, there's some evidence that males, who are the predominance of patients in any center, really, about 60 to 65% of Parkinson's patients are males, it seems, for whatever reason we don't understand fully, may be more at risk for developing cognitive impairment. Other disorders may just fall more along epidemiological lines in the general population. So for instance, depression is more common in women in the general population than men. And that's probably true for Parkinson's disease as well.
Got it. Okay, great. Thank you so much for addressing that. Thank you everyone for joining, and thank you again so much, Dr. Weintraub, for your time. I know we went a little past 8 o'clock. Thank you, Dr. Chitnis, for doing such an excellent interview. We have recorded the session, so if you guys need to go back and watch it, or if there's someone that you think would benefit from this information, we will be sending out that link along with a couple of resources. I know we didn't get to answer all the questions, you guys, and I'm sorry for that. I hate when we have questions unanswered, but this was just such a hot topic, and we just had so much engagement, which we love, but unfortunately we weren't able to get to every single question. However, there are some resources that I will send out that may help answer some of the basic questions that were asked. There are some papers that I found that Dr. Weintraub himself has authored, as well as some resources from the Parkinson's Foundation. And there's a podcast as well from the Parkinson's Foundation that covers some of what we talked about. So if that's something that you guys are interested in, I will definitely send that out to you. And hopefully that will help answer some of these questions that were left unanswered. And with that, one more thing. Mental health for PD, got a lot of questions about psychotherapists who are familiar with dealing with PD. I'm trying to compile a list of people in Texas that meet those qualifications. Some of you guys have shared some recommendations from the different areas that you guys are tuning in from, so thank you for that. If you guys have any recommendations, any personal experiences that you've had with any psychotherapists that are familiar with PD, please share that with us so that we can share it with our audience. I'm sure people will benefit from that, and hopefully we can compile all of that into a list and send it to you guys. Thank you, Shilpa, for putting that link. I am going to...
Yeah, if you can just email it. This is a review article that my group had put together a couple of years ago. I think it's, it's very comprehensive.
Wonderful. Yep, I got it. I will include that in the resources that we'll send out to you guys.
Dan, thanks so much for all your great input.
You're welcome. Thank you for the invitation.
Thank you both. Thanks everyone for joining. We hope to see you again soon. Bye, everyone.